Okay, we have Dr. Nathan Murray here today. I'm so excited. When I met Nate a couple months ago, I was like instantly blown away by just like your easy energy, Nate. Like any problem that we seem to talk about in the space that you're in, it seems like no problem to solve it easy. So, how about you introduce yourself and kind of tell folks a little bit about your story?
Cool. Hey, Alex, thanks. I'm Nathan Murray. I'm an ED doctor. I helped to co-found the AI tool Doc Assistant. So when I graduated from residency coming up on a year and a half ago now, I felt like there was no tools that really thought like an ED doctor. So like they kind of saw the patient with you and like generated a differential diagnosis, ordered tests to narrow the differential, treated, and then disposed the patient. So I thought it was a clear application of AI that kind of wasn't created yet. So I paired up with my longtime friend Pietro Sette, who's a software engineer, and we created an AI interface that would kind of try to think like an ER doctor. So like the initial prototype, you would just type in information about your patient, and it would generate like a differential, testing considerations, treatment considerations, and then disposition recommendations. And then we strengthened it a little bit. We partnered with StatPearls and integrated all the StatPearls 10,000 articles that they have published on PubMed into the AI to kind of like layer it on. We ragged it on, and then took it a step further and did the same thing with WikiM, and to where it'll actually bring in the WikiM link directly into the recommendation, and you can click on it and it'll bring you to that page, which is really useful on shift, bringing that information to you. We found with early users over a year ago now, where that like it was a cool tool, but it was hard to type in all the information on shift. On a busy ER shift, it wasn't really super practical. So what we did is we layered in an AI scribe where the phone listens to the conversation between you and the patient, and then from that it'll actually auto-generate all those recommendations. And we also built in the functionality of normal AI scribes as well, which are very popular at this point. Where it'll generate HPI, physical exam, MDM. It'll even do reevaluations where it'll timestamp every time you update the patient encounter. It'll be like, this is a summary of the reevaluation. And since then, we've been building, iterating, trying to make it more and more useful. We found a lot of success with our MDM specifically, kind of optimizing them for the medical director and for reimbursement. So pretty much I went through the 2023 CMS guidelines and added everything that was important in that into our final MDM outputs. We've had some pretty good success with current customers in their improvement in billing. We're seeing on average like $128 increased billed per patient after Doc Assistant implementation. So helping a lot with physician RVUs, department reimbursement, from really comprehensive MDMs. The clinical guidance was the initial mission essentially. And so that's still like a very important part to us. We've iterated a lot. There's an in-platform chatbot that you can ask any questions to. I had a really complicated patient where I had like a complicated hand fracture, and I was like, I think it's just an ulnar gutter and I can dispo. What I did, we actually built in a photo upload option where you can take photos of any imaging interpretations, labs, things like that, which is really useful. So I took a picture of the image interpretation. It automatically incorporated that in the note, but then I also asked the chatbot, and I'm like, what splint do I use for this? And can I dispo them without admitting? Because it was like a common infraction. And they're like, yeah, it's a ulnar gutter, which I thought, here's the WikiM article that you can read more about for these specific fractures and it being an ulnar gutter, and it should be suitable for ortho follow-up. And it was just a nice extra thing to double check my intuition, what I thought, and brought all the relevant info to me directly. And it was like a pretty cool edge case. But a lot of people use the photo upload just for the benefits of how it improves the note too. So like it'll analyze all the labs for you, and it'll incorporate that into the clinical reasoning and everything for the MDM, which is nice. So yeah, I mean, that's kind of where we are. And like since then, we've just been iterating, working directly with doctors and trying to make the best product possible. The goal is just to have a really useful AI co-pilot. Today it does, note writing, clinical recommendations. Tomorrow, I hope that it does all the administrative stuff that we'll need in the ER. Maybe one day we'll add like a option where it'll automatically call in your prescriptions if you need to through an AI agent. if it's a outpatient office, I would like it to where we can communicate with patients, schedule appointments. We're going to build more and more clinical guidance, and we're hoping to partner with UpToDate at some point in the next, in the coming months, and bring that in as well as some drug dose companies, make those clinical recommendations stronger and stronger. Would like to maybe even make like local antibiotic sensitivity implementations at some point. So, a lot of areas where we can expand the tool to make it better. But
That's
right
amazing. So let's go back a little bit. Let's rewind. So how did you decide, what was going through your mind in terms of deciding whether to work with you said your co-founder was your friend? Like, had the two of you ever had a business endeavor together before?
No. So initially, actually, I didn't want to like ask him to try to work with me, just because like I didn't want to try to tell a long-term friend, or try to work with a long-term friend. Everyone always says don't work with a long-term friend. So I was actually using him as a point of reference, like, hey, I'm talking to these engineers, I have this idea, this is what the engineer, he's in Austria, is charging. And my friend's like, oh dude, he's ripping you off, like that doesn't make sense. And I was like, oh gosh, do you want to do it? And then he was like, okay, I'll do it. And then we did like a trial run where we like built the prototype and everything. And after 3 months, I paid him initially. Like I was what I was going to pay the other guy. He took way less, but after 3 months, he's like, hey, I really like what you're doing. I think it's cool. I like working with you. And I'll come on, like, and you don't have to pay. Let's just build this together. So then he became like a co-founder. So that was kind of how that relationship progressed. And he's been really great to work with. It's hard to find other people that like really truly want to get stuff done all the time. And so it's really nice. It's really relieving when you find someone that has kind of that same innate desire to like get stuff done quickly.
I think like I've started a ton of little businesses over my life. And one of the hardest things is if you do have a co-founder or more than one co-founder, it often ends up in a situation where one person is carrying more load than the other. And it can create all sorts of kind of weird tensions and, negative feelings. Yeah, what are your thoughts around that, about how to avoid that? Because you guys are still pretty early with all this, right?
Yeah. I mean, so now at this point we have really a team of 4, and everybody kind of has an inherent drive to work. And I haven't had to deal with that yet.
That's amazing.
Yeah, it's just kind of lucky, I guess. So I don't think I have any good advice on how to avoid that, because, like, for instance, ASAP was last month, and all 4 co-founders were like, we're going to be there for sure. Like everyone was there grinding, everyone was there selling, both the engineer co-founders and the sales co-founder. We're all selling together, and we're all doing, we're working afterwards on product, and every week everybody's just so. That's amazing. Yeah, it's just lucky, I guess.
So, when you guys started this, there were presumably already a number of players in this space. So what made you think that it was worth coming in to this space where there's all these big names also doing, something moderately similar? And what's your special angle?
Yeah, I mean, actually, the reason I created it was because I thought there was nothing in the market, and I still don't think there really is, like an AI clinical guidance tool for ED doctors specifically, like one that thinks.
Well, if you narrow it that way, right? But there are like these AI scribe tools that are like massive, right? So I guess that's your angle, right? You're saying for this, like, we're gonna go hyper focused on one specialty and their unique needs in a way that the more generalized solutions aren't, right?
So I think two answers to your question. Like, we actually didn't set out to make an AI scribe company when we first started, right? Like it happened as like a necessity because people didn't like having to enter information in. So that's how it kind of organically became more of an AI scribe company. Once we entered the AI scribe market, where we found our point of differentiation specifically was less in the clinical guidance and more just making a really good MDM and in making a tool that's useful for the ED workflow. Because there's not many companies that do that very well. So like once we found that, that's where we found, once we narrowed it really strongly, that's where we started to find more traction and like have gotten, like a legit user base and stuff.
Yeah. So, I talk to a lot of founders and they come to me, they're like, hey, I have this cool idea and it's going to make this positive impact on like the US healthcare system in some fashion. And when I ask them who's going to pay for this and why, that's where like 90% of them stumble, So I think the key thing here with your solution is that you're really helping. I mean, one of the main value streams here is you're helping folks document more accurately and make sure that they're getting the most accurate visit level for the work that they're doing, right?
Yeah.
So I think that's like a primary driver. Or what are the other kind of other value streams that are top of mind for folks who are using this?
So I think the biggest value add for clinicians off the bat is the same that all the AI scribes have benefited from, and that's just like offloading of having to document, which is just like a crazy amount of time saving. I'll share an excerpt from a doctor that we have in San Diego. He said that his whole career for 20 years, he always booked 4 shifts in a row, and the 5th shift was off for notes, and he would always take about 5 hours to do notes. He found our product, and then he called me on that Friday, and he's like, dude, this is the first time in 20 years that I don't have a note to do on the 5th day. Like, he's like, my wife is so happy. I'm so happy. He's like, it literally saved me 5 hours this week. Like, I walked out of every shift with my notes done every time. So the biggest gain, I think, comes from the time saved, given back to the doctor, and also just like the mental offloading that allows you to not worry about, like, you don't have to sit down, you don't get, interrupted by 3 nurses while you're trying to dictate a note, and then like that constant task switching. So that's the biggest thing. The reimbursement stuff is cool. It's definitely helpful, especially to sell to medical directors and stuff like, hey, look, we have like tangible improvements in overall reimbursement. Doctors like it because a lot of doctors are RVU based or partially RVU based, so it improves their direct pay as well. So that's a huge value add as well. And then I think the clinical guidance is still useful. The people that implement it more, seem to be more APPs. I think it's really useful, especially for if you haven't, done like a residency training, you're maybe a little less confident in your differentials. Just nice to double check, like, oh, did you think about PE? Should you order a dimer? Like, at least run it through a well score, and like at least try to think, like, is there something that we're missing here? So I think that that's really useful. And over time, I think that we're going to figure out ways to incorporate the clinical guidance more naturally into the workflow, where it's going to kind of be next to the provider more rather than them having to go seek it out. And I think then it'll continue to like improve patient outcomes, which is the ultimate mission from the beginning.
I think that's like the holy grail, right? To have that clinical guidance in like just in time, right? Or the right clinical guidance for the right patient at the right time, easily consumable.
Yeah.
And so I love how you guys are incorporating that and then connecting to the trusted resources, right? The wiki EM and all of that. That's brilliant. I really love that.
Yeah.
And so talk to me. There's another aspect of this that I think is really interesting, and that's your bottom-up approach. So most of the other big vendors in this space, they're trying to sell to the health system or to the EHR itself, but you guys are going directly to the frontline provider. So talk to me about that.
I mean, if I had a giant, private equity backed institution behind me that allowed me to tap into their distribution network and I could just go sell directly to a bunch of hospitals, I would probably try to do that because that sounds much easier. We don't have that. We're a founder-based group. Like, it's our company, and we don't have, like a giant Envision or Team Health or anything kind of pushing us. So the most natural solution for us to get exposure is through product-led growth. So we, let people try it for free on the website. You get 50 patients. And that's how we've gotten pretty much all of our traction, is users trying it. We'll talk to them. They like it. Then they can introduce us sometimes to their medical directors and to their friends. And that's just kind of how we've chosen to go about it. And I think it's helped a lot. We've seen really good growth for like 6 months in a row. I think we're averaging something like 60% month-over-month growth. So it's working. It's like the most important metric to me is like how many patients they're seeing each week using Doc Assistant. And if I see a dip, I'm like, what happened? What's going on? And so, yeah, that's kind of my like theory on how we be successful is we just need more patients being seen with it week over week. And then if we're doing that, then that means that we're creating a tool that's actually useful, and it'll naturally be successful, I think.
So for those who are listening who don't know, so basically a doc or an APP could go to the Doc Assistant website and just start using this without necessarily getting the permission of anybody.
I mean, ultimately, you should still definitely, ask the patient if you're going to use the AI scribe part. Is it okay if I, record to help me write my note?
Yeah.
Patients are almost unanimously okay with it. And then other than that, I mean, like we're HIPAA compliant end to end, of course. Like all processes that we do are immediate. Like all of the information is immediately deleted on the back end. The only thing that's stored is the patient note in a secure server for 3 weeks, and then that's automatically deleted from the face of the earth as well. So, I mean, it really depends on the department. Some urgent cares are much more flexible. What I've found is actually some ERs are even more flexible. Some are more strict and require a top-down approval. Met with a medical director yesterday in Norfolk, where I went over and they need to get institutional, approval. But once they do, like then they're going to try to implement this. And so it's just really department specific, whether like how strict they are with like trialing it and stuff. And but what we found is that in large part, like ED doctors do have an appetite to try it on their own. They want to know, especially medical directors and stuff, because they're like, hey, if I want to pick a product for the whole department, I want to try them all and I want to see what works best. And so we get a lot of organic product-led growth that way, which it was surprising at first because emergency medicine is very department based. I think like if you're like a primary care doctor using an AI scribe, like a Get Freed or whatever, it makes a lot of sense that it's your practice, you try it, it's easy. And so that was an assumption that I think we made at the beginning that was actually wrong, that we weren't going to be able to get a lot of product-led growth in the ED, but that hasn't been the case. Actually, people do like to use it and try it, and then they're even like they'll even introduce me to their medical directors, and then the medical directors start to implement system-wide. So that actually has worked.
What's the typical profile of like your ideal customer right now? Is it mostly in the community, or is it academic, or?
I think that community definitely has more of a use for it. For one, academics still often have residents. They don't care about their notes getting done as much. So that's like, there's less need there. Community is going to be more RVU based often.
Right.
So we have a clear level of, a clear bump of improvement there. Our ideal user is a medical director. But any ED doctor really is our ideal customer at this point. We did create frameworks for urgent care, inpatient, outpatient. We actually have several live like paid inpatient groups as well. We have one of my friends from college actually also, I brought him on. He's a hospitalist now. And so he kind of writes those prompts and for like the H&P notes and kind of handles that and the onboarding and that stuff. So we do other specialties as well, but we spent a lot of time making it really good for acute care settings. It's got like a reevaluation section. Every time you like take a picture and upload photos or eval and do a quick audio update, it'll timestamp and summarize it. It is just built to kind of flow with the ED workflow.
Are you interacting at all with other folks who are building specialty specific tools like AI tools in other specialties?
No.
I haven't seen that. Yeah, I've seen a lot of this general solutions. So it's like,
I have made friends with one of our competitors, CEOs. They're doing a really good job, and they've like gotten a lot of ton of market share and stuff. But so I kind of share, battle stories with him, specifically like prompt writing and stuff. Like, hey, did you notice that 4.0 seemed to change last week? Like, yeah, it did. Stuff like that, where it's like, just talking about like model specific stuff and prompt stuff, and it's been interesting to kind of bounce stuff off of him. Outside of that, it
is interesting if you do a lot of this sort of coding with AI and using AI for like large volume of stuff, you do start to pick up on the nuances of the various models. And I'm always on Twitter and I see like the OpenAI folks announcing a new model, and it's like they say, oh, it's like when they announced 5, it was like I don't know if you remember, Sam Altman published a picture.
Oh my gosh! What a scam that was. I was like, great, our nodes are gonna be so good. And every model release, I'm so disappointed. I always run 10 hypothetical patients, and I run it versus my 4 outputs, and I run it against 4.1, 4.55, and they're always worse. 4.0 is still the best for me, at least like subjectively. I know our hospitalist likes the 5 outputs actually more for his assessment and plans, but they take so long to generate that it's like
they are slower.
But I still like 4.0, honestly. I don't know if you've got a subjective preference with
Yeah, I'm still using mostly 4.0 and 4.0 mini. It's
Yeah.
fast, it's very accurate, it's quite affordable. Yeah, I totally agree.
Yeah, I'm curious of your opinion. I feel like just from the last year and a half of these releases, they've all been letdowns. I'm starting to think that like scaling GPU clusters isn't increasing intelligence. Like, do you kind of feel the same way?
I agree. I think where they do seem to be getting better is with like tool use and like I would say for my coding uses, like 5 has been marginally better than 4, but like I was just running some general math tests again for GPT-5, and it was significantly worse than 4.0, and I couldn't.
Yeah, it's crazy, right? Like 4.0, they must have just had the best run ever when they did that. It's like, how old is it? Like almost 2 years or something now. It's like it's kind of crazy.
Yeah.
I know our CTO switched from Claude to 5. He's like, it's slightly better when he uses Cursor, but like I think it got a little bit better at coding, but that's pretty much it. Like it didn't get better for the ER outputs. It didn't get better for clinical reasoning for sure. Apparently it got better for like verbose writing, like assessment and plan type writing.
Amazing. So what does the future look like? Where do you think this is headed in in a year or two? Because anything beyond that I think is really hard to predict.
I mean, I don't know. I'm going to listen to our users and the market, just because like that's one lesson that I've definitely learned, is that like it doesn't matter what you think is going to be cool. It's like matters what people actually use and are willing to pay for, which is a hard problem to solve. We're starting to do some talks with some billing companies about partnering with them, seeing if we can maybe like offer our product through their distribution networks, and then also maybe even work with them to like optimize the notes for them so that their billing is easier. Interestingly, we're talking to a human scribe company to see if we can like white label our product to them to improve their product, because they don't have an AI scribe built their product yet. So those are 2 areas that we're exploring. I think ultimately there's like 2 pathways right now that like we have to kind of decide as a company, and I'm still not totally sure which the better of the 2 is. Is like there's right now obviously AI scribes is a very competitive space, and EHRs are starting to add them on, to be determined how well they actually execute that. But I think that like the 2 clear pathways of differentiation are clinical decision support and then RCM stuff. So like do we want to start taking on more of the RCM load ourselves? Like, can we become more and more of a billing company over time? Like, can we build infrastructure that allows us to gather EHR data and actually do the coding for them? And like, are we willing to take on the lift to talk to payers as well? Like, it's a very, very difficult problem to solve. And I don't know if that's the correct use of resources, but it potentially could be. And then the other thing is like just going really hard down the clinical decision support path, kind of like whatever that really means. Like, I wonder like what open evidence really even truly does. Like, I feel like they're just a series of prompts running on 4.0, to be honest with you. Like, our 4.0 is like better sometimes. Like, I don't know what they like, but like, I do think that there are ways that you can bring more and more useful information to the user. Kind of like the model of just like bringing lots of citations in and clickable links, and then figuring out ways, like you said, to kind of like nudge the provider at the right time without being annoying. This like potentially could help them with guidance is like kind of the holy grail there. Also a really difficult problem to solve. One thing we're going to try to do pretty soon is we're going to switch to the more cursor interface, where like you can actually like interface. It'll be like a sidebar, and then we're going to start to integrate it where you can like tell it like, hey, change that part of the node, or what do you think of this, and try to make it more interactive with the overall platform. We're going to explore that. So I don't know exactly what it's going to look like in 2 years for us. What I know is we do have a solution right now that people are paying for. And so we're going to continue to grow that and continue to get revenue, and, try to just keep building what people are willing to pay for right now. And then as the market we're going to explore the different paths and kind of see where we actually get interest and traction. And then we'll probably pick a lane between the 2. Between RCM and clinical guidance, and probably go pretty strong with it. And then over time, hopefully just keep expanding the different capabilities of the platform once we like actually nail each individual one. which I found to be much harder and more time consuming than I initially expected when I set out to do it all. But yeah.
One interesting angle to think about is like real-time or near real-time surveillance and monitoring on provider performance. So when I was helping run our ED group, we created this program. At that time, we had human scribes who were basically following around every shift. And so we tested this program that I built out where the scribe, not only were they documenting like, all the notes, but they were keeping tabs like on like in a spreadsheet, how many patients you saw. And there were a few other things that we also were tracking, like the 7 behaviors that we wanted the docs to do with every patient in terms from a patient satisfaction perspective. Like, did you introduce yourself? Did you hand them your business card? Did you shake their hand? Did you sit down and actually pause and listen to them? Or did you interrupt? Did you avoid interrupting them in the first 30 seconds when they're telling their story? There's this whole checklist. So then what would happen is at the end of your shift, the scribes would input this into some like Google form or something, and it would auto-generate a report that then got emailed to that provider and their medical director.
Oh boy, I'm sure they love that.
It was a double-edged thing, because if you had, let's say you saw a bunch of patients and you knocked it out of the park on patient stat, then you got this positive reinforcement from your medical director, instantly emailing like, oh my God, like Jennifer, you did an amazing job today. Thank you so much. And it was so powerful getting that, because otherwise, like a lot of times, like your medical director might not be there that day. They don't even know that you carried the whole ER that day. You saw 40 patients, like, holy cow, that's amazing.
Yeah. It is interesting that like once you finish residency, there's like really no system of like analysis on your performance at all. So it really makes sense that you need something. We're going to introduce something pretty soon, like a MIPS, like a general MIPS platform for groups where we could say like, hey, you're giving antibiotics to X amount of like URIs, things like that, so we could prevent like those massive CMS fines. That's definitely on our pretty soon to do agenda. It just creates some like engineering work on the back end, like creating like a de-identified thing and stuff for that group. But that's something that we totally want to do. We've thought about doing, we talked about it like internally, and I think it'd be really useful for groups if we could provide some of that kind of global overview. Start there. Definitely. I mean, it makes sense.
I think there's a really interesting angle there, right? If Doc Assistant starts to provide like data to the medical director and department level about how the various providers are doing on various, dimensions that matter, whether it's quality, patient satisfaction, productivity, like if you start to provide that, like that could be a really amazing angle, right? It's not easy, as there's obviously a lot of things to figure out there, but what I'm constantly thinking about with your company is what's the wedge that you can have that the big generalized solutions are generally not going to do, right? Like they're not going to create ED performance reports, I doubt.
No, I mean, it's so far as to the big solutions, like a bridge, I don't even think they do an MDM. Like it's so much.
Wow.
Like it's like not hard to differentiate at all within the EM market. And then like within the several EM solutions, like you can take it a step further too, and like really standard, like optimize for the 2023 CMS guidelines and stuff. So that's been where we found our differentiation. It's just like, oh, cool. I know emergency medicine. I know what we need and what we want. I know how our HPIs are written. I know how MDMs like can be optimized maximally to reimbursement and communication to the next doc. And then like, that's kind of where we found it. But
there's another interesting angle here that I've been thinking a lot about, after being introduced to you, Nate, and that is the idea of whose AI is it, right? So, think about this, like for the last year or two, a lot of folks have been using these AI note takers on every Zoom and Google Meet and all that, right? And in that model, everybody knew because that somebody was using a note taker because it would join the meeting and it was visible. But then this company came out, Granola. I don't know if you've seen it or used. So it's an AI note taker that doesn't that you use, right? But it does not show up as a participant. It connects to the system audio and it's listening, and it basically, so they're essentially bypassing the kind of the rules around making it totally public that you're taking notes or not, by saying, listen, we're not recording the session, we're just helping the user take notes, right? And there's like this gray zone of, well, like, okay, if you're not actually recording it, do you necessarily have to announce to people that you are doing? So there's a lot of Silicon Valley folks who are using Granola now, and so the other party has no idea that there's actually a note taker listening in and essentially documenting, the conversation, right? And so I take that and I think about the emergency medicine space where, the hospital and their kind of enterprise EHR may have some sort of AI documentation tool, but the docs, in addition to that, may just want to have their own note taker on top of that, regardless of what, because you and I know, like, most of the times the enterprise solution is just garbage, right?
Yeah. Well, if a bridge doesn't have an MDM after 4 years, I don't think that Oracle and Cerner are going to nail it anytime soon. So it should give us plenty of time to continue to accelerate in this space, at least. So yeah. That's interesting. The Granola thing. Yeah, it's going to be interesting what laws come out from all of this. I mean, it seems like there's just we just live in a world that's just like universally recorded, and like there's just no way around it, unfortunately. Yeah.
Well, I love this whole, like, we had this bring your own device thing, and now it's like bring your own AI, right? Like, that's the world that we're headed into, and that's what you're building for the emergency medicine docs. I love it.
Cool. Yeah. Thanks. It's been fun. Thanks for helping out.
All right. Thanks, Nate.